Hello, good afternoon, everyone.
Good afternoon.
So it's 2 o'clock on the dot. I think we can begin. So my name is Obinnia for those of us joining this session. I'm the Executive Director of Advocacy for Civic Engagement Center. Advocacy for Civic Engagement Center is a youth-led CSO that is using creative technology to facilitate civic engagement and policy dialogue with the government. Of course, we are working with the House Committee on Media and Public Affairs to drive their sectoral engagements. This is the final session for this outing between the House of Representatives and the health sector. And so far, it has been really good. It has been insightful. It's been engaging. And if you joined us in the last session, you see that a lot of actionable outcomes emerged from our dialogue. And really soon, we'll be seeing some changes made by way of legislative interventions, bills, motions, flowing from the conversations that we've had so far. The idea behind the sessions is to create an ongoing constant channel of engagement between the key stakeholders of each sector and the legislature, especially to make sure that policies and legislations are not wanton, but are based on consultation and evidence as premises for legislative interventions. So I would like to welcome everybody here today and very quickly establish the protocol. Honorable Benjamin Kalu, the Chairman of the Committee on Media and Public Affairs, who is also the official spokesperson of the House of Representatives. Honorable Martin Okezie, the Deputy Chairman of the House Committee on Health Institutions, who is also representing the Chairman of the House Committee on Health Institutions, Honorable Pascal Obi. All honorable members of the 9th House of Representatives present here and represented. Professor Namadi N. Sambo, the Executive Director of NHIS. Senator Olanrewaju Tejuosho, who is with us today, the Chairman of Legislative Initiative, LISDEL. Dr. Frances Ilika, Country Director of Palladium for Health Policy Plus. Mr. Obinnia Abajue, CEO of Hygeia HMO, who is also with us today. Mr. Lanre Olapoju, he's an Associate Director with KPMG. He's also with us today. And of course, I must recognize our very able moderator who has piloted our conversations from the beginning of this engagement, Dr. Nkem, and she's the CEO of Preston Development Foundation. She has over 25 years of experience in health program evaluation, service delivery assessments, M&E, accountability mechanisms, health policy analysis, the whole works of the health sector. She has worked extensively. She still consults for United Nations agencies, UN agencies, including the WHO, the World Bank, as well as major international donors such as Bill and Melinda Gates Foundation, DFID, among others. She's also a fellow of the Royal Society of Public Health UK. And she has really, through her organization, been representing the Nigerian health sector in the international space. Her experience has really helped to elicit, productive discourse from this engagement so far. So we really acknowledge her here today. We also have Dr. Chioma Nwakanma. She is a public health expert. She's the founder of Smile With Me Foundation. She's a healthcare thought leader and a TEDx speaker with years of experience in health communication and advocacy, sexual and reproductive health and rights, leadership and project management in healthcare. She's the communications director of Medically Speaking Africa. And like I mentioned earlier, she's the founder of Smile With Me Foundation, an NGO that leverages the digital health technology to reduce mortality rates from preventable diseases through impactful outreaches in low middle income African communities. She's also a 2020 fellow of the Young African Leaders Initiative, YALI. So I'd like to welcome everyone to this session and permit me, having established the protocols, to hand over to our able moderator, Dr. Nkem.
Thank you very much, Barrister Obinnia. I really do consider it an honor to be here, and I thank the ACE Center for setting up this platform. So however I can add value, I'm happy to be part of that. Just to acknowledge our panelists, I stand on existing protocol, and I just wanted to just assure you that we will do our best to accommodate all the good work that you're doing and to let you do your presentation completely. But I would just please say that this webinar is supposed to be really interactive, and we're trying to save some time for the end where people can ask questions. So please do your best to kind of try to restrict yourself to an 8-minute. We have an 8-minute interval for presentations. Just allow all the speakers to have their say and allow the participants to dig in at the end of the session. The other thing I will say is that those that are standing by technically to support for the slides to be made available timely, so that there's no lag time between when the speaker is supposed to be making their contribution and when the slide is available to be looked at. So with that, I'd like to invite Professor Mohammed and Sambo, the Executive Secretary of NHIS. Before you speak, sir, and thank you very much for being here, I would like to read through your bio for those who are not really familiar with, your background. Actually, I don't see him on the panel yet. If he's not here, I can move to someone else. Okay. All right. So we will move instead to Senator Lanre Tejuosho, who I'm familiar with his work.
Excuse me.
Yes.
Yes, sorry. Permit me to also mention that we have with us Dr. Felix Ogedebe. He was with us in the first session. He's the MP CEO of Cedar Crest. He had very insightful contributions to the first session, and he's joined us today to also lend some voice to our conversation today. So you're welcome, sir.
You're welcome, Dr. Felix.
Yeah, thank you very much. Thank you.
Over to you, moderator.
Okay. So Senator Lanre Tejuosho, thank you very much for joining us. I'm very familiar with the work that you've done around the National Health Insurance Commission bill, and we look forward to your contribution right now. But there may be some people in the audience that do not know your background. So I'm going to kind of just read through what you've been doing, just so that people are familiar. So Senator Lanre Tejuosho is a medical doctor who served as the chairman of the 8th Senate Committee on Health, for the National Assembly in 2015 through 2019. He's a prince of the dynasty of His Royal Majesty Oba Dr. Adedapo Tejuosho, CON. He has several titles, and he has also served as Commissioner for Youth and sorry, my computer just and sports, environment and the environment. He has also served on the Ministry of Special Duties in the state. In 1981, he was admitted into the University of Lagos, where he obtained his MBBS degree and later accomplished his specialties in telemedicine and medical computing abroad. He became a doctor at the age of 21, making him one of the youngest doctors in Nigeria. He completed his national youth service at the Nigerian Port Authority Medical Hospital, where he participated in the National Youth Service Corps scheme. After his service here, he had a brief stint at the Tejuosho Hospital, now Iyaode, please bear with me, Bisoye, Tejuosho Hospital, where he practiced as a medical officer. So we're definitely, and now he's currently the chairman of LISDEL, which is an NGO that looks at the legal framework that supports our health system. So thank you very much, and you're very welcome, distinguished Senator, and we look forward to your presentation. Please go ahead.
Thank you very much for the very brief introduction, and I thank you for inviting me. Distinguished colleagues, ladies and gentlemen, let me begin by putting in context the comments I will be making today. In Nigeria, we have defined universal health coverage as the goal of our health systems, and health financing reforms are the core of strategies to move in the direction of universal health coverage. Therefore, the discussion of a topic like this within the context of universal health coverage needs to be guided by three key principles. Number one, the countries that have made progress in universal health coverage have done so with a predominant reliance on compulsory funding sources like general tax revenues, marked payroll taxes, or a combination of both. Let me emphasize that all countries that are recognized to have made substantial progress towards universal health coverage have relied predominantly on compulsory funding sources like general tax revenues. Secondly, countries that have made significant progress towards universal health coverage have had the benefit of a strong political commitment to universal health coverage, reflected in the prioritization of health in their national budgets. Thirdly, where there's a challenge in public financing, there's a trend towards greater diversification of revenue sources. So let us apply these three guiding principles to Nigeria. First, it means that for Nigeria to move rapidly towards universal health coverage, we need to rely on public funding. That is, monies raised by the government through taxation. The challenge we have in Nigeria, however, is twofold. There is low participation in the formal sector, where 70% of Nigerians are in the informal sector, and our revenue-raising efforts is abysmally low. Our current revenue to GDP ratio is 8%, which is one of the lowest in sub-Saharan Africa. It means that even when we want to abide by our first guiding principle, the country is not making enough public financing. I'll come back to this point, but let me move to the second guiding principle, which is there must be strong political commitment to the principles of universal health coverage. Strong political commitment. You see, when there's a will, there is always a way. The United Kingdom National Health Insurance was started in 1948, right after the Second World War. The same for countries like Thailand, who began universal health coverage reforms after the Asian financial crisis. What you can learn from this is that despite my comments that our revenue to GDP is low, if we are committed to the principles of universal health coverage, then we will prioritize public financing for health. The third guiding principle also seeks to address the issue of constrained public financing, as I have described for Nigeria earlier. This is where we have some governments or institutions trying to raise money from individuals through premiums for health insurance. Let me emphasize, this is a challenge and has not been successful. The transaction costs are very high, and it's easier to improve tax collection efforts. So, what is the way forward for Nigeria? Number one, Nigeria must increase its revenue-raising efforts. If we don't raise enough money as a country through improving our tax rate and tax base, our colleagues in the Federal Ministry of Finance and Budget Office will always complain that there's no money. However, in this regard, I must commend my colleagues in the National Assembly and the executives for passing the recent Finance Act of 2019, which substantially has increased the amount of public financing available to government. However, increasing revenue does not necessarily translate into additional money for the health sector. And this is where political commitment is critical. It is this commitment that spurred myself and my colleagues in the 8th Assembly to appropriate a sum of about 58 billion naira in the 2018 appropriation for the first time. With political commitment, we can enshrine additional public financing for health in legislation, as we did for the Basic Healthcare Provision Fund. I'm glad to know that this Basic Healthcare Provision Fund is now a statutory transfer in the appropriation. Let me digress a bit on this political will, because really, year in, year out, we have these conferences, we have all these meetings, we have all the beautiful proposals, ideas. But what is really, really the missing link is the political will. I'm glad this is a conference organized by the legislators. The 58 billion I mentioned just a few minutes ago, it is the largest padding ever in the history of Nigerian budgeting. And it is the most successful padding we've ever had, that there was no complaints from anybody, because it was a padding that we all need and the country needs. It is a padding that is supposed to change the health sector for good. It is a very welcome padding. I know that the executives, before that particular introduction of the 58 billion, we went around the executives and they told us it was impossible to inject the Basic Healthcare Provision Fund. But with the political will of the Senate and the House of Representatives, we were able to inject the 58 billion. So that is what is crucial as a take-home for us at this time, the political will of the government and the politicians. My last point is the role of mandatory health insurance and role of health insurance broadly. During my tenure as chair of the Senate Committee on Health, we completed a review of the NHIS Act, which will make health insurance mandatory in Nigeria. But this was not signed by Mr. President. The current NHIS Act makes health insurance optional. This cannot be so. In the spirit of solidarity and cross-subsidization, health insurance must be made compulsory. But this is only complementary to public financing. The role of health insurance at this point in time is especially critical in how it helps to pool all the financial resources together and then in turn transfer the funds to public and private providers through strategic purchasing. In summary, without public financing, we cannot achieve universal health coverage in Nigeria. However, we need strong advocacy and stakeholder engagement, like I got during my tenure, to actualize Basic Healthcare Provision Fund. But beyond the financing raised, the role of health insurance is particularly vital in how it pools the funds it has received, and in turn, how it uses the principles of strategic purchasing to buy services from public and private providers. I thank you all for listening.
Thank you very much, distinguished Senator. That was really informative. I think I like the vibe coming from our legislative arm. In the morning, we had Honorable Martins talking about the need for smaller government and the need to have fewer advisors and things as a way of expanding the amount of money available for health projects. And here you are as a senator talking to other members of the House to increase political will, and also talking to the executive arm at the highest levels to do the needful. So it's really refreshing to know that we have an ally in the legislative arm. And I can see the impact that the CSOs had on your on the things you were able to achieve during the 9th Assembly. So thank you very much, sir, for your contributions regarding the role of mandatory health insurance. If it's optional, we cannot make progress. So we really do appreciate your contributions. Okay, so next on our list is Dr. Frances Ilika. Is she here? No. Okay. So we can take someone else. Okay, so let's move to Mr. Lanre Olapoju. I know you're there, the Associate Director of IDAS KPMG. I just skipped something, sorry. Let's talk to Obinnia Abajue, who is the CEO of Hygeia HMO. For those that don't know him well, I will read through his bio and just give a sense of who he is. So just, get yourself ready to make your contribution. Mr. Obinnia Abajue has over 20 years experience in banking and financial services, primarily in Nigeria. Before joining Hygeia, he was based in South Africa in charge of business transformation for the Standard Bank's personal and business banking business in Africa. He served as executive director and head of personal and business banking for Stanbic, and he was also the acting chief executive officer of Stanbic Pension Fund. He holds a bachelor's degree in actuarial sciences from the University of Lagos and has an MBA from the Imperial College London. He is a fellow of the Institute of Chartered Accountants in Nigeria, and he's a member of the Chartered and a fellow of the Chartered Institute of Bankers of Nigeria, and as well as the Chartered Institute of Stockbrokers of Nigeria. So you are very welcome, sir, and we look forward to your presentation. Please go ahead. Remember that you please have 8 minutes to deliver your presentation. Thanks.
Thank you very much, and good day, everyone. Thank you for having me. So it's very, very interesting and encouraging when you go after someone like Honorable Tejuosho. We all kind of look up to him to see the things that they are doing at the legislative end of the conversation. But very quickly, are you going to put up my slides? I have a set of slides to go through. Are they going to be projected?
Yes, sir. They're going to be projected shortly. Okay.
All right. So just to set a quick context, do have a handful of slides to go through, and then I won't touch to everything, but I'm going to try to get through them as quickly as possible given the time constraint. But my task has been to look at how to improve the business terrain for health insurance in Nigeria, all right, focusing on challenges and recommendations for the health insurance system. So to do this, what I've tried to do is to focus on why health insurance is important, all right? Then I tried to put some numbers around the market potential, all right, and then key challenges and recommendations, as well as a few additional recommendations. As a practitioner in the marketplace, our focus is really around trying to get results. So at the end of the day, there are many different ways, many different thinkings around stuff, but ultimately, if we're going to deliver universal health coverage to Nigerians, then we have to be very focused on how to actually deliver results. There'll be some in the short term, some in the medium term, and some over the long term ultimately. But it's important to understand how these things will happen. So I believe that health insurance is a very important pillar for the Nigeria in particular, and I'll explain why. We're a resource-constrained society. So our GDP per capita is quite low at about 2,300. And that takes us to where we have to acknowledge that we, on a per capita basis, are a poor country. And in doing so, the principles that we need to work with are to pull our resources together and achieve what we want as efficiently as possible. What that means, therefore, is that we've got to be very prudent with how we handle our money. And then all our plans ultimately must be scalable. And we'll have to look for how to allocate resources in a way that actually is effective. And that effectiveness we've seen ultimately, globally actually, is tending towards health insurance. All right. Every society is finding that they must have a public-private partnership to deliver the outcome that they want. And everywhere they're increasing the access to private health insurance so that the governments are able to focus more on the vulnerable and those that are less able, and subsidizing the parts that are difficult to cover from a private perspective. Now, I'm going to spend some time on this slide because I want us to understand how big the private market potentially can be and how important it can be to the discussion. And once you put numbers around something, it helps people to get a sense of its importance and size. So how big is this private market potentially? First of all, let's use real numbers. So we went and took the numbers from the National Pension Commission report, where they were highlighting what exactly the covered population is in the formal market. So if you use the National Pension Commission numbers as a predictor of the formal market, that has been described as roughly about 8.6 million, of which 5 million is private sector and 3.6 million is public sector. Now, if you work those numbers in, what you will get based on an assumption of the family sizes in the marketplace will give you a population of roughly about 34 million people in the formal market to be covered. And today, the NHIS has a voluntary contribution premium of about 15 million naira per annum per head, which means that on this basis, this market is estimated at roughly about 500 billion. It's about roughly about 1.2 billion naira US dollars annually. Now, distributing this money into different pockets gives you a sense of how these monies can be distributed to make them effectively allocated, right? Some of the things you see, for example, is that the revenue paid to NHIS out of these fees is statutorily 1% of the revenues or the premiums mopped up. That's about 5.2 billion. All right. And you can break it down into different parts to show how ultimately the government not only generates additional tax revenues, jobs are created through payroll and payments, and government generates PE through it as well. And if you think about the amount that goes into the private and perhaps public medical services, it's about 416 billion, roughly about 80% of the premiums based on a standard medical cost ratio. So how do we harness these opportunities? A few things that need to be done. One is that the data is not in the open. Next slide, please. All right, the data is not in the open, and we need to get data out there because the data helps us to ensure that we understand and all practitioners can work towards maximizing the information available. So we would need the NHIS to publish the data since it is a central aggregator, so that different parties can look at it and look at how they can play. All right. And I think that it will be very helpful to get all financial reports by all players in the marketplace to be published like every other financial industry does. Next slide. Next slide, please. Okay. So one of the things that there are two things that we think that are critical to helping the market succeed. All right. Two things are critical. One of them is rules. We need to remove regulatory ambiguity to make it easier for people to come into the marketplace. We need clarity around the NHIS's operation, whether they are competing or they are regulating, so that the management of the government service is very clear. All right. We also need state government roles to be clearly demarcated because health is on the concurrent legislative list. So there must be a clear demarcation between what states do and what the NHIS does, so that there's no overlap and practitioners can know exactly what they are doing. Importantly, HMOs need to be regulated at the national level, not at the state level. You need clear market rules as well to make pricing easier, all right, with rules around benefits and limits and all that very, very clearly improved. And you need an ombudsman. That's someone that can help to mediate disputes. Next slide. The next set of things that we need to do, which is even more important, is to provide support for demand aggregation. All right. Now, Honorable Tejuosho had mentioned the importance of making health insurance mandatory. All right. So that is important, but that's just one of many things. The other thing actually on the other side is to actually make it mandatory for providers to collect insurance and not cash. So whilst you are pushing, you are also pulling. Now, if you do both, you will find that the demand for subscription to health insurance will rise dramatically. Now, if we ensure that all employers and governments, that's the compulsion, are then contributing for their staff, that makes it easier. And the government can move upstream to high value activities like emergency care and tertiary services that are more difficult to insure. Now, we attract risk capital into the marketplace, so we need to review capitalization rules so we can make it attractive for the big boys to come into the marketplace and invest in this market, all right? And then we make it transparent through publication of information and define rules very clearly so our risk pricing is more easily done. Next slide. A few other recommendations that make it easier for the insurers to work and to scale very quickly is that we stay with the market principle. It's so important that because we are trying to assure efficiency in resource allocation, demand and supply forces must interact. So what we're trying to do ultimately is to make the sector bankable so it can be leveraged for success. The second recommendation I think that's really important is the fact that we need to take a position as to what we're going to do with government expenditure. Because the government is being encouraged to spend money in healthcare. But where exactly should the government spend that money rather than dissipating it across the entire value chain? And I will be recommending that the government is better spending their money on supply side interventions, because these are high cost, high value, long-term investments. Education and retention of medical service personnel. We need a minimum wage for medical services personnel to attract them, to keep them, and it has to be benchmarked on the quality of life index so that the people that are joining medical services can have a minimum quality of life and they are focused on saving life. All right. Standardization of primary care formulary, because that's a place where there's a lot of leakage. All right. But it's important that we drive the production of drugs locally because that gives us healthcare security. And then finally, it's investing in educating our population about health insurance and why it is prudent as a way going forward. It's a bit of a rush, but I've got to the end of it. And I think that I'll be open for questions subsequently. Thank you very much.
Thank you very much for that presentation. Yes, we did kind of rush you, and I could see that you probably could go for another 30 minutes if we let you. But we really do appreciate your contributions. I particularly like what you said about, the regulatory ambiguity that currently exists and the lack of transparency, not lack of transparency intentionally, but data is not available. The industry data has not been available to other players in the market, enabling that market to become more advanced and more sophisticated, particularly around risk pricing and that kind of thing. The way that the NHIS is currently structured, there are questions around whether it is viable as originally put together, and that was the impetus, I think, for the bill that was put together and worked on. So, we will see if the NHIS executive director is able to join us at some point during this discussion. But during the interactive session, I'm sure there will be questions about how health insurance.
Yeah, sorry, the NHIS, they mentioned that they're having connection issues, so they are trying to join. So as soon as they join, we can take them on. So, but for now, we'll continue.
Okay. So yes, what you're saying about market rules need to be understood and made clear to all the players in the market, just so that we can really start talking about big money in health. And until we make that a more predictable investment, it's unlikely to happen. So I really do appreciate your your perspective from the business side about what is possible. Thank you very much. And we now have Dr. Francis Ilika with us, who is the Country Director for Health Policy Plus. I will briefly read through her bio as she prepares to present, just so that those that don't know who she is can really get to get a sense of her background. I would also ask that Dr. Francis, if you could please put yourself on video. We'd like to see your face so we can match your face to the name. I will start now. So Dr. Francis has experience in health system strengthening, including healthcare financing, governance, human resources for health and service delivery. She has facilitated the formulation, legislation, and design, implementation, and monitoring of strategic health systems reforms, including, all working towards universal health coverage. Her work experience includes facilitating the establishment of multi-sectoral coalitions across finance, health, and the private sector with parliamentarians, CSOs, all towards universal health coverage. She has supported innovations, including the legislative network for universal health coverage and piloting for several public-private partnership models towards increasing access to universal quality of healthcare. In her current role, she has progressed efforts towards the integration of HIV and tuberculosis into health insurance through policy formulation, stakeholder engagement, evidence-based decision-making as well. She has a degree in medicine from the Nnamdi Azikiwe University in Nigeria and has a master's degree in public health and health economics from the London School of Hygiene and Tropical Medicine. So, Dr. Ilika, can you please start your presentation? We're really happy to have you. So please go ahead.
Thank you very much, Nkem. Please, will the facilitators allow me to share my screen? Good morning, distinguished honorable senators, members, distinguished heads of institutions, distinguished colleagues. I would like to add my voice to this conversation that is going on today. And I am trying to share my screen. Okay.
I think you joined after I had already put out the kind of house rules that every presentation has 8 minutes. So just keep that in mind. Thank you.
Great. Thank you so much. Can you see my screen now?
Yes.
Excellent. Yes. So I think a lot of speakers who came before me have actually highlighted why universal health coverage is very important. But basically on this slide, I just want to highlight that when we're talking about universal health coverage, there are some key goals there, which one of them is universal. Everybody, no matter who you are, what you look like, where you live, whether you have money, whether you have a job or not, whether you live in the rural area or urban area, whatever your situation in life is, you have the right to access health services. And this health services cuts across, as we can see from the screen. And they're not just having this wide range of health services, but of adequate quality so that you can actually feel better and have a good quality of life. So that is actually very important. And then of course, you should be able to access this care without having financial hardships. So basically without getting broke. So being able to access all the care you need. And then equity is also another very important role. So if we understand these principles, then it makes it very easy for us to understand the things that we need to do. Now, coming to Nigeria, how is Nigeria doing with regards to universal health coverage? So there are a lot of parameters and targets or benchmarks that have been set out. And as we can see from the screen, Nigeria is not doing very well. With regards to government health expenditure per capita, the recommended is at least $86 per capita, and we can see where we are in Nigeria. Of course, other people, Senator Tejuosho, have spoken about Abuja Declaration, which incidentally was passed in Abuja, but we are among the last people to, make progress in this regard. And then, of course, perhaps the last one, which is looking at level of financial risk protection, we can see that Nigeria is still at less than 1% coverage of the population with regards to financial risk protection. A lot of countries have made progress with regards to universal health coverage, and I'm sure that Nigeria will not be left out. So a lot of efforts have actually gone in. A lot of great, excellent policies have been passed. But right now is the moment for us to walk towards universal health coverage. So I'd like to very quickly look at some of the challenges that the country has been encountering so far. So I know there is a very big debate out there. Should it be general tax-based method towards covering the population, or should it be health insurance? Now, Nigeria has a lot of challenges on that each of these methods. With regards to general tax-based systems, like GDP ratio is a big problem. We're collecting just about 8% of our GDP as tax or as revenue. We can see other African countries, the sub-Saharan African average is about 18.9%. And we can see how we're faring. We see our neighbors, Kenya, Ghana, they are doing so much better than us. And some of these countries, their GDP is not even up to 1/3 or 1/4, sometimes 1/10 of the Nigerian GDP. So we can do so much better. Of course, we have a very large informal sector. So it's very difficult to actually collect revenue from this. So this creates a problem as well. In addition to this, even the tax mechanisms that are in place, there are a lot of administrative inefficiencies. So a lot of these tax don't even make it back to the government. So despite the very large GDP, and there is a lot of low compliance. And then of course, there are a lot of conversations around, we need more progressive tax mechanisms so that we get more money from the rich, like it's being done in so many other countries, than taxing the poor, taxing consumption and things that the poor will benefit from. And then of course, even when we're able to get this taxation, like we could see, we're still at 4% of the total allocation to health as a percentage of the total allocation of the total budget. Even the one that we're able to collect, we're not prioritizing health when we're distributing this. Consider and need to work towards, if we're talking about moving towards a general tax-based system to finance universal health coverage in Nigeria. With regards to health insurance, of course, this is the current system that we're using, but it's also very, very much plagued by a lot of challenges. Of course, we have a very complex health system. Some people have already highlighted this. That is why we've not moved very far. With states having the right to make certain decisions. That was why NHIS was not able to have a universal single pool, which is the recommended, and it's been decentralized to states. Now, even at the state level, there's very low prioritization and low political commitment, as has been highlighted by some previous speakers. So many states have passed their state health insurance laws. They have 1% of their equity fund to go towards health insurance. But even as we speak, many of the governors have not released of the funding for even the formal sector workers that should go towards making this health insurance schemes a reality. So these are very big challenges. The informal sector, the missing middle, how do we reach the informal sector? Because they are meant to contribute. How do we get these contributions to them? Because this is a peculiar problem. It's a sub-Saharan African problem or a problem that is peculiar to us. The solution will not come from the Westerners. The solution has to be homegrown. So this is a very big issue that we need to address. And then of course, suboptimal technical capacity, as well as awareness. Some of my other colleagues have mentioned this. Now, I think aside this big debate with regards to should we do tax-based or should we do health insurance, there are some key principles which are perhaps more important than the label or the name that we decide to give whatever mechanism that we're using. So it's very important that we move towards a predominant reliance on public compulsory funding sources. So it needs to be a public system. The money must be collected in advance. It must be predictable and stable. So whatever system it is that we're using, and there should be a complementary system from all these different sources. It needs to be redistributed so that we can have this equity that we're talking about, this universality, so that everybody, no matter where you are, will be able to access it, whether including the people who have been able to contribute and the people who have not been able to contribute. And then of course, we must use this money in an efficient manner. So basically, this is my last slide. Where do we go from here? So we need to ensure that all financing sources are harmonized and that they complement each other. For instance, right now, the health insurance system we have in place is that the state health insurance schemes are meant to cover their whole population. And the plan is that over time, all of this will be aggregated at the national level so that we can have a single payer system like it's ideal and like is working in other countries. But even the state's health insurance schemes are having a lot of challenges. So the government subsidies that need to be there for people who cannot afford to pay needs to be prioritized. The formal sector contributions will need to actually begin to happen. Many of the states will need to approve this, and even the employer contributions are very important, and all of that needs to start happening. Informal sector contributions, like I mentioned earlier, contributions from the missing middle. Perhaps this is the bulk of the population. We need to figure it out, and the solution has to be homegrown. It needs to come from us. What works for us? What can we do? What are our cultural practices that will help us collect money from people? And then, of course, the Basic Healthcare Provision Fund, the legislators have actually made a lot of progress in this regard. And it's very important that the Basic Healthcare Provision Fund is integrated into the state health insurance scheme so that it can cover for the poor and vulnerable. And the revision of the guideline has actually made this possible. Political commitment, I won't spend a lot of time here because Senator Tejuosho has actually emphasized this to a large extent. So it is very important because if we have states who are not releasing the equity funds for the poor and vulnerable, who are not even releasing takeoff grants, then how would these schemes take off? And how do we begin to make this progress towards universal health coverage? So we need that at every level, at the federal level, state level, even local governments. We need everybody to to these schemes. And then, of course, we need to make sure we allocate, making sure the laws and oversight to make sure that the funds are released. So a lot of times they pass the laws and then these funds are not released and nobody does anything about it. And then civil society plays a role as well to demand accountability from the people that they have elected to make sure that these funds are released. And then the plan, the ideal thing is that we should gradually move towards a general taxation system. So while we're trying to put together all we have and make the best of all we have, multi-sectoral action, the powers to actually make general taxation work, our finance colleagues, people, the parliamentarians, civil society, everybody needs to come together to talk about how do we grow our tax base? How do we have these tax reforms that will improve the revenue that government collects from our GDP so that we can actually begin to move towards this ideal of a general tax-based system. So I'd like to stop here and I'd love to contribute further during the question and answers. Thank you.
Thank you very much, Dr. Ilika. I mean, it's very clear that you are well versed in this whole healthcare financing and insurance, health insurance subsector of health. I just wanted to kind of talk about the highlights for me in your presentation. And it doesn't mean that all of it was useful. But I mean, my real take-homes were when you talked about the role of, the importance of the missing middle and how the informal sector seems not to be as visible. And I mean, for obvious reasons, the informal sector forms a huge chunk of our economy, but many of them are very mobile, they're not as rooted as the formal sector. And that's why it's been difficult to organize them to make, meaningful contribution to the health insurance discussion. I know that there was an effort by the NHIS some years back, I think it was 2012, to formalize them in a way through their mutuals, through their cooperatives, and use that as a proxy for many of the people that exist in that subset. Okay, so thank you very much. And I think right now we will move to the next speaker, who is, now we will have Mr. Lanre, Olapoju, if you're ready.
Sorry, excuse me. If I could just button now, we're able to get Professor Mohammed Sambo, the NHIS ES, has joined us.
Okay. All right.
So
So thank you very much. I don't see you. Okay. Yes. Okay. So good afternoon, sir. You're very welcome to our panel. I know you're still connecting to audio. Good afternoon, sir. You're very welcome to the panel today, talking about health insurance and how it works in the Nigerian health sector. You're up next, I hope you know, and if you're ready to make a presentation, we'll be more than glad to hear it. Some issues have already come up around, the way that the sector is currently covered by the scheme that we have nationally. For those that don't have the background of Professor Sambo, I will be reading out his bio as he settles down for his presentation. So, Professor Sambo.
Good afternoon.
Good afternoon, sir. I was just reading out your bio for people that may not be familiar with your background. Professor Sambo is the Executive Secretary and the Chief Executive Officer of the National Health Insurance Scheme. Before his appointment, he was a Provost, College of Medicine in the Kaduna State University. Professor Sambo is a Professor of Health Policy and Management. He has a very enviable academic and operational background in healthcare finance. He has kind of worked in quite a bit of the health sector. He's risen through the ranks of the NHIS. I think before then, he was posted to the National Primary Healthcare Development Agency as an assistant director and zonal coordinator in the Northwest Zone. He has served as a member of the Ministerial Technical Working Group that developed the National Healthcare Financing Policy, which is a framework that facilitated the flag off of the NHIS way back in 2005. So he's been around and is very relevant to the origination of all the work that the NHIS has been doing. And we'd like to just welcome him to the forum to make his contributions and for us to hear him out for his presentation. So I know you may have a lot to share, but given that this is an interactive session, we are trying to ensure that there is time for our participants to also ask you questions. So we've kind of set the time frame for 8 minutes per presentation. So we really appreciate you just kind of bearing that in mind as you present. Thank you so much, sir. Please go ahead.
When you are in I had to leave my house to another yard to stay outside to get connected. So I'm very
so we're having a problem hearing. Okay. So for the bandwidth, you can leave off the video if it helps. So you just to use your audios, just so that we can hear you. It appears your network is a little. So if you want, you can turn off your camera and just focus on your video. On your audio, and we'll try and follow the conversation.
Can you hear me now?
Yes, sir.
Okay, excellent. I'm very sorry for joining late. I have tried, but the connectivity failed me. But better late than never. Discussing about health insurance system within the balance of healthcare financing arrangement is one of the topical issues. There are so many reasons why the focus on healthcare financing, because of the insufficient fund that has characterized the global system and health system not exemption. Another reason why we are focusing on the healthcare financing is the issue of uncoordinated resources, limited knowledge on policy instruments that can be utilized to get healthcare financing very well. Looking at the insufficient financing, insufficient resources, we are talking about issues where country based on their GDPs are not being able to meet the recommendation of many institutions, many financing institutions. And this poverty, for example, 15% that has been agreed upon in Abuja Declaration, there is another value of $56 by WHO Macroeconomic Commission on Health, and so many organizations, international fora, where recommendations have been made. But when you come to the issue of developing countries, the financing is even more challenging because of the pervading poverty. Majority of the people are below the poverty line, and there must be a lot of work in order to have an adequate financing arrangement to guarantee sustainable funding of the healthcare system. But generally speaking, from the healthcare financing balance, we are talking about no one single financing mechanism is sufficient to provide the needed financing for the healthcare delivery system. That is why it is advocated to have as many healthcare financing options as possible. And looking at these options, healthcare can be financed through general tax revenue, through public means such as general tax revenue, such as donor financing, such as utilization of social health insurance and other financing mechanisms. Then there are other issues that has to do with private and passive private financing of healthcare system, such as private health insurance, user fees, and other initiatives like individual saving accounts you see in some other countries. But generally speaking, there are criteria that are used to ascertain which financing option is the most appropriate. And these criteria include capacity of the financing option to mobilize sufficient resources, capacity of the financing option to engender equity, and capacity of the financing option to ensure sufficient efficiency in financing the healthcare. But when all these options were put in place, it was discovered that social health insurance scheme is, in terms of equity, is the most progressive. There are so many classification of equity. It can be seen as from perspective of horizontal equity or vertical equity. And the vertical equity can be progressive, retrogressive, or even proportionate. But when all these healthcare financing were put into the scale of financing, it was discovered that general tax revenue is progressive, social health insurance is progressive. But within the context of this discussion, we are looking at tax-based financing. If we are looking at tax-based financing, we are now focusing on, first, how do you generate revenue for financing healthcare through general tax revenue? And when you are talking about generating fund through tax revenue, you need to understand the various taxation mechanisms, the direct and indirect taxes, so as to be able to harness as much resources as possible within the taxation system. You are talking about export duties, import duties, personal income tax, as well as other taxation mechanisms like value-added tax. So if you are generally looking at ways to increase the GDP and increase the fiscal space, you need to understand this various method of taxation, that is the direct taxes, the indirect taxes, and be able to study each one of them and be able to ascertain how much each taxation will bring into the coffers of national economy, and how much proportion of that will go into the healthcare delivery system. So as a healthcare financing expert, we need to be interested about various taxation that are in Nigeria and various amount of the quantum of resources that is coming through this taxation. Because this taxation is what enable country to pay salaries and what enable country to determine what premium can be generated for financing healthcare system through the taxation. So the more the country is able to generate taxation without leakage, the more you have more funds within the system, and the more you have a proportion of money that is coming to the national coffers that will go to the healthcare delivery system. Let me give you an example. If 1% of consolidated revenue will go into the healthcare delivery system for basic healthcare provision fund, of which 50% will go to the national health insurance. The more you are able to guide your tax and be able to generate taxes that will come into the consolidated revenue, the more the proportion of that 1% that will come to the healthcare delivery system, and the more the proportion of that 50% that will come to the healthcare national health insurance scheme. So as healthcare financing, we need to focus more on taxation and ensure that government is generating the needed tax that is required. But even if you generate all the taxation in Nigeria, you will realize that the amount of money that can come will not be able to provide the needed healthcare, because you need to look at the gross domestic product, GDP. The mainstay of Nigerian economy, you can see, is from the oil sector. Therefore, a health sector is interested to see that there are fiscal policies that will allow for diversification, so that you now have more varieties of ways in which the GDP can grow, and when you have more
Okay, it appears we're having some audio issues from Prof's side.
More money coming when you have an increased resources within the balance of the health insurance scheme. Hello?
Yes, we can hear you, sir.
Can you hear me?
Yes, sir. Please go ahead.
Okay. The National Health Insurance Scheme, I have alluded to the fact that it's one of when you put the various financing options into the scale of financing, the National Health Insurance Scheme is one of the progressive healthcare insurance. That is why it is advised that countries should have health insurance, because one of the appealing feature of the healthcare social health insurance is ability to engender cross-subsidization. You have a budget, you have money coming into the healthcare system based on the functions of the healthcare system, capacity, resource mobilization, resource pooling, and resource effective and transparent allocation. The National Health Insurance System has capacity to combine all these elements of healthcare financing. It has a capacity to mobilize resources. It has capacity to mobilize pooling, and this pooling will allow for cross-subsidization. The rich can subsidize for the poor. And it has capacity to tap general tax revenue, where budgetary provision is made, money is allocated, and it will end up in mega contracts without targeting to an individual. But in health insurance, there is a prepayment mechanism. If the money is coming, you know the number of people to be covered, and you target them through registration and production of identification card, so that when they are sick, they move into the healthcare facility and get treated based on their ability to join the National Health Insurance Scheme. Unlike in general tax revenue or any other financing, which has no component of prepayment mechanism. For example, if the money going to the basic healthcare provision fund is just allocated as allocation to the healthcare delivery system, it will end up in contract, which might likely be hyperinflated, and at the end of the day, is not really targeting to an individual. So that's why the National Health Insurance Scheme is very appealing in the healthcare financing system. And the National Health Insurance Scheme in Nigeria has gone into a serious turbulence. It is supposed to, ab initio, be a mandatory social health insurance. But unfortunately, on the 13th May 1999, when the law was, when the national health the decree came out, it came out as a voluntary. Many actors refused to join the National Health Insurance Scheme, and therefore deny the National Health NHIS the needed resources to galvanize in attainment its mandate of universal health coverage. I have doffed my hat to distinguished Senator Tejuosho, who has worked assiduously in the 8th Assembly to ensure that the law, the mandatory law, is passed into law. But unfortunately, it came out on the eve of their departure, and the law has not been assented to by the president. But now we have rekindled that movement. We are happy to. I'm happy to state here that the Senate has passed a mandatory law. We are pursuing the House of Representatives to be able to concur or to concur with that law. When we have this mandatory law of the National Health Insurance Scheme, it therefore means that it is mandatory. It is mandatory. All the states, all the public sector, state, local government, and federal government will join the ecosystem. All the private sector will join the ecosystem, and we have developed a very creative and innovative program within the National Health Insurance Scheme known as GIFT-SHIP, Group, Individual, and Family Social Health Insurance Program. The Honorable Minister of Health has supported the development of this GIFT-SHIP program, and we are hopeful that on the 26th May, on the 29th by 10 a.m. by the Honorable Minister. The appealing feature of this GIFT-SHIP will allow individuals to come into the National Health Insurance Scheme, will allow family, a private family, to come into the National Health Insurance Scheme, and it will allow even group of people or group people that are binded with one form of reason or the other to come into the National Health Insurance Scheme. It will also be extended to diaspora. Our colleagues, our relatives are there in diaspora making a lot of money, which if they send $1 or $2 will be able to cover so many people within Nigeria, and this program will be marketed to them so that they can also generate resources. In spite all this mechanism of generation of resource generation, the quantum of money that will come through the National Health Insurance Scheme from public, from private, and from individual will not be sufficient enough to cross-subsidize for the large teeming population that are poor. We need to develop innovative healthcare financing strategies. We are working, the National Health Insurance Scheme is currently working with D8, and very soon we have made a proposal to the Honorable Minister to establish what we call National Committee on Healthcare Finance, of Innovative Healthcare Financing, where we will generate and harness and generate all ideas of innovative financing. Some people have talked about removing one kobo from telecommunication industry for every one call that has come in, so that all the money generated will come into the National Health Insurance Scheme to provide for healthcare. By their own calculation, I know the Kuru Group, the last year graduate of Kuru, has made a presentation to the Mr. President that such kind of innovative financing is required to provide the needed resources. They have made their calculation. This one has tremendous capacity to generate billions of naira to ensure subsidy for the poor who cannot be able to pay. So we want to have a committee, a national committee on innovative financing, where all those initiatives can be tabled and discussed, and be able to do a lot of advocacy to address, to support that initiative, so that the teeming vulnerable group of Nigeria can benefit from that initiative. We cannot succeed, no matter how far we have gone in this 21st century, without automating our national, our system. I'm glad to tell this gathering that on Wednesday, we made a presentation to the Federal Executive Council for the ENHIS, which is supposed to be a magic bullet that will overturn the modus operandi of the National Health Insurance Scheme. And I'm happy to report to this gathering, the first public gathering that I will address, that President and Federal Executive Council have graciously approved the ENHIS roadmap. The most interesting thing that should be noted, NIGDA, an organization that is responsible for reviewing all IT projects in Nigeria, has looked at our roadmap comprehensively by their experts, and they discovered that among the 100 MDS they assessed, the National Health Insurance Scheme roadmap is the most comprehensive and most realistic, and therefore awarded National Health Insurance Scheme with best interoperability readiness agency. So we have moved from this readiness to implementation. When we made a presentation at PEC on Wednesday and the approval was granted, I quickly summoned the NACOMSAT and all implementing partners that are supposed to deploy this program, and we have gone far. Very soon the work will commence. The time period of deployment of this ICT will be several months. So what I'm telling this gathering is, within the next few months, we will see a very rapid transformation of National Health Insurance Scheme through automation of business processes. And in addition, we are also looking at total automation of enterprise resource planning within the National Health Insurance. And in anticipation to that, we have collaborated with Digital Bridge Institute. We are undertaking a systematic training of our healthcare of our staff. So far, through the Digital Bridge Institute, we have been able to train about 180 staffers of the National Health Insurance Scheme, and the training will be ongoing. There is a project that will ensure that for the total automation, all the staff of the National Health Insurance Scheme will not only be proficient, but super proficient in handling ICT tools and systems, so that by the time we deploy the ENHIS project, the operation will be seamless. Currently, there is ongoing training of our staff. If you go to our state and zonal offices, there is ongoing training to prepare the staff of the quantum of people that are coming to register under the gift ship program, which will also be tally with our ENHIS project. A lot of activities are going on. I need to say that we have stabilized the system, a situation whereby healthcare providers providers are fighting with HMOs is fast fading away. Very recently, we have undertook a reconciliation exercise. We have been able to recover about 2 billion from HMOs to healthcare facilities seamlessly without any noise. A lot of activities are going in the National Health Insurance Scheme, and given the support by all the stakeholders in the ecosystem, by next year, the National Health Insurance Scheme will be a magic organization in terms of enrollment, in terms of improvement in its business processes, and in terms of having a very clear roadmap of attainment of universal health coverage by the year 2030. So I think I will pause here. If there is a need for me to come back, then I will come back and continue.
Thank you so much, sir. I mean, your passion is on display right here. I think there's so many innovations going on. I don't know where to start. I think the ones that really excite me the most is the automation of the processes. I mean, I was just thinking the other day we saw as part of the NSAS protest, the warehouses where there were palliatives, and I heard from a member of government the reason why the palliatives were still in the warehouses because there was a difficulty in getting them to the people. So I was thinking that if health finances need to be pooled, and then, you know, how do we get all that money from all the various sources into one pool? How do we get the pool money now to the people? I mean, that would take forever if we have to approve pieces of paper. And so to hear that there is a holistic and very systematic way of doing this electronically, it makes a lot of sense. And the other thing that really excited me was the gift ship initiative, which is looking at roping in the diaspora people. The diaspora people generate so much money. I mean, there have been several reports from Western Union about how much money transpires between the other nations and Nigeria, just relative sending money to other relatives. So, and it's usually for healthcare. So if we can somehow automate, you know, enable them to key into what is happening electronically, I think it would be easy for them to even cover more people. So I'd like to really thank you for those contributions. We have 2 more speakers to make their own contributions. I would like to say it's currently 3:15, and it's really important that you stick to the 8 minutes that we have allowed so that we can go to the interactive session, allow people to ask questions. So, Mr. Lanre Olapoju, you can make your presentation, but just allow me to quickly read you a summary of your bio, just so that people can understand who you are. And if you can make your please put your video on so that people can match the faces. So Mr. Lanre Olapoju is a management and public sector consultant with significant experience in the management of public sector projects. He has a bachelor's degree, first class civil engineering from the University of Ibadan, Nigeria, and is currently the associate director in the infrastructure, government, and healthcare practice of KPMG, with specific responsibility for the international development advisory. His projects have included assignments in primary healthcare development, universal healthcare coverage, business plans for hospitals, and monitoring and evaluation of projects. His career spans a period of 2 decades consulting for a Big 4 consultancy group in Nigeria, or for the Big 4 big consultancy groups in Nigeria across industries such as public sector, healthcare, trading, banking, healthcare, power, and telecoms. So Mr. Lanre Olapoju, the Associate Director, International Development Assistance Service, KPMG, can you please begin your presentation now? Thank you so much.
Thank you, Dr. Nkem. Good afternoon. While my slides are being put up, I think just to make a few comments. So good afternoon, members of the National Assembly, ladies and gentlemen, this session. It's always, there are pros and cons, you know, to being, to speak after many eminent speakers, you know, have spoken. The pro is that you get to agree with all of them, and I do agree with everything that has been said. The cons are that you may be repeating some of the things that have already been said. So it also allows me to be brief, so that we can have the questions coming in. If you can go to the next slide, please. I'll be talking from my perspective, as a professional service provider to the health sector, both on the public side, private sector side as well. The WHO, recently, did a publication just looking at investments in the health sector across Africa. And the conclusion was that Nigeria is a lower middle income country whose health investments are commensurate with that of a low income country. So what it means is that we are really punching below our weight. We have a GDP of about $448 billion. And financing and our inability to actually pull out that financing from the $448 billion is really one of the major roots, of all the issues we have in the healthcare sector. With 228,000, we are short on doctors, and even the ones we have, there's a brain drain. They are all running abroad because, they can earn more money, doing their stuff out there. The shortfall in bed capacity, about 350,000, across the healthcare sector. Our population that don't have any health insurance at all, estimated at about 90%, So the root of it really is that if we can get the financing right and we can direct the financing well, we would get to where we really want to be. Next slide, please. The big takeaway I want from this slide, we don't need to read everything. I'm not going to go through everything, but I must acknowledge, some of the recent efforts, across government and also in the private sector. It's a movement, that has begun, and across regulation, various reforms like the primary health care under one roof, the reduction in the disease burden, Nigeria has been certified free of the polio wild virus. I think these are things we need to celebrate. The National Health Act, the Basic Healthcare Provision Fund that Senator Tejuosho led proudly, which was, very good for the health sector. Also, we are seeing quite a number, from my vantage point, working in KPMG, a number of private sector investments, and PPPs, things are scaling up. I think what I want to take away from this slide is, yes, the movement has started towards universal health coverage. Yes, some of the money is coming in, even though it's in trickles, but I would really like to see, a very coherent plan, around universal health coverage. There must be a presidential level plan that we are all pursuing. The NHIS is chipping in, the primary healthcare development agencies chipping in, the state governments are chipping in, the private sector is chipping in, but at the moment, I just kind of feel that the reforms are a bit piecemeal, and there needs to be a very coherent plan with all the actuarial studies done that everybody is working towards. Next slide, please. So talking about financing, I just wanted to put these figures up. For me, this really answers, all the questions, the answers, that I want to put down here. And here I'm comparing Nigeria and what we've done with our financing, comparing us to about 6, 7, 8 other countries and what they've done. I just quickly like to point you out to the life expectancy figure, the very one at the top there, which is the overall indicator really for the health outcomes of your country. It's 84 for Japan. That's the largest in the world. So if you are a Japanese, on the average, you get to live 84 years. The highest we have 79, the US, the UK, and Japan. And I've just circled it in red there, for our benefits. And I'm just going to be looking at what these countries have done with regards to financing and how they did it. The first lessons, I want to take away just looking at these figures is our public health expenditure as a percentage of GDP. Virtually all the speakers before me have mentioned this. At 4%, we are nowhere near what other countries are doing. Others are doing way ahead of us. So you see it is 11% for Japan, 17% for the US. But when you look at the public health expenditure, you begin to see that there are actually two sides to this equation. So the question about Do we do tax-based financing? Do we go health insurance? It's a very simple question. It's a very simple answer. Sorry, you have to do both. Okay, so if you look at the UK, about 83% of their expenditure is coming from the public sector. Japan is all tax-based financing. But when you look at the United States, it's almost like 50-50. So there's a lot coming from private sector, which is like health insurance, and also a lot coming from tax-based financing. So the answer is simple. We need to do both. We need to ramp up our tax revenues from the government side. Government needs to bring in the money to stabilize the system and give it the foundation it needs to grow. And the private sector individuals must also buy health insurance and contribute their own quota. That's the only way we can get out of this rut, that we are in. Next slide, please. And then the question comes, it's something I would like to, to tackle here. When the money comes in, I think even for the money that we have at the moment, there is a bit of, we may not be spending it in a way that it is quite smart. So what I've done here is to just put together like a potpourri of all the challenges we have in the health sector in Nigeria today. And I've tried to divide it along the things that are for the public that government can focus on and spend this money on versus what government should leave and allow the private sector to take care of. So the private sector should be taking care of things like investment in hospitals and health centers. Government, as we know, is heavily invested in that space traditionally with all its teaching hospitals, general hospitals, and all of that. The inadequacy of doctors and staff are things that private sector contribution to financing can resolve. The poor quality of health, if the health insurance is there, if the money is coming in, the government through tax-based financing can look at resolving more systemic issues, around the accessibility to care in remote areas, which is primary health care, helping to decrease the cost of care, helping to ensure that there's health awareness in the country. Nigerians are not spending on their health. They will rather buy from the agbo seller, that is, by the roadside rather than go to a hospital. And it's all about the low health awareness. And these are things that government money should be going into, to try and fix. And then there are other problems that both government and the private sector must collaborate to fix. And things around inadequate pooling and risk, inadequate funding and risk pooling, which health insurance sits in. The issues around the weak capacity to implement programs, etc. So for me, even for the pot of money that we have today, we need to be clever in terms of how we allocate who is spending money on what and which sector actually takes care of what. Next slide, please. So this is my last slide. I've just brought out about 5 points which are top of the mind for me to say what should be the suggested solutions going forward. So I've said, number one, it's not a debate between tax-based financing and health insurance. We need to do both. We can't run away from that. Senator Tejuosho spoke about the need for the strong political will. That's extremely important. There must be a strong political will to broaden the tax net and to enforce mandatory health insurance. The NHIS DG spoke about that just now. It must be mandatory. The financing must come from compulsory sources. The second thing I think is there must be a strong communication on the benefit of UHC, to the citizenry and ensure they are buying. This is where I think the NHIS requires more funding, to really do a very good job. Nigerians are really not aware, of how they can get involved, why they need to buy health insurance. And it may not be their fault. Poverty is pervasive in the land. Discretionary spend, there's really not much, that can go around. But the truth is that you only need to get sick, and the sickness only needs to be serious for you to know, that you actually spend all of your money. So there's a lot of communication that needs to go out to educate Nigerians on the need to buy health insurance. And I think that communication needs to be in different languages, should be at different levels, and it needs to be strong, it needs to be consistent. And I would imagine someone like the NHIS, an organization like the NHIS, should actually be the ones, taking that forward. The third thing I want to speak to here is in implementing health insurance. This is coming from KPMG's experience. As a global service provider, we've done this across many countries. We always advise you go for breadth before width. And this is what we mean. The population coverage should be pursued first before the expansion of services. The mistake we make is, I was talking to the Lagos State Health Insurance Scheme, the executive secretary, some months back. They were trying to, they were doing the actuarial studies to say how much, is the basic plan going to cost? Can the average Lagosian afford, to pay the premium, etc. The issue is, even if it's only malaria that you want to do universal health coverage for, that government can fund for the bottom of the pyramid. I'm just giving an example, right? It's not going to be only malaria. If it's only malaria that you can walk into a hospital and get treated free and get your free drugs, go for the breadth first. Get the inclusion first. Get people first into the net. Let everybody buy in before you begin to then scale up the services. It's always breadth before the width. I think I should really emphasize that point. The fourth thing I would like to talk about here is the citizens. I think I've spoken about this, should contribute to the financing of their care. We all know that government financing will not do it. And that's why I said it's a dual strategy here. We need to ramp up our tax base, right? Even though the 15% Abuja declaration, the truth is 15% is not a magic number. If they give us 15% of federal government revenue today, it is still not enough, to take care of the health challenges in the country. The issue is really about the absolute value of that amount. And that comes to what exactly is government's income, and with the need for us to actually ramp that up. And then the fifth point, and this is where I will stop, it's a model I've seen work in Bangladesh, which I believe Bangladesh is very close, in a way to some of the poverty challenges we have in Nigeria. And they've been able to successfully pilot things like telco-based microinsurance. So they sell microinsurance, just using people's phones. One of the things that have been successful in Nigeria is almost everybody has a phone, even down to the villages, some even have smartphones, all right? And so what we were able to do was to say, okay, look, let's get, anytime you do a recharge, why don't we, just take a tax, from the recharge, that you've done. And that goes into paying your, your premium. So those are some of the initiatives that we can begin to look at to resolve some of these financing issues that we have. I think I should stop here because I'm cognizant of our time, that it's fast spent this afternoon. Thank you very much.
Thank you so much, Dr. Lanre. I think it was, I learned a lot from what you said. I fully agree with what you're saying about breadth before depth. Even when I look at Nigeria's current World Health Minimum Package, the minimum package that they use it's being used for the Basic Healthcare Provision Fund. It has everything on it. It has HIV care, it has ophthalmology, it has all sorts of stuff. Instead of looking at the top 10, what are the top 10 diseases that any Nigerian walking into a clinic is likely to have? And if we focus on that, I think we'll be able to cover more people instead of being able to give everything to the few people that it makes. So I fully buy into that recommendation. And thank you very much for talking about the need for strong communication on the benefits of UHC. I agree that, the typical Nigerian is willing to spend so much money on a burial than to spend less money on going to the right place to get the right health. We've seen that over and over. Somehow people are able to finance very grand burials for their loved ones instead of financing, much better, higher quality care. So in the interest of time, are we still, I know that Felix is on hand. Felix, I know we rushed you the last time. I'm about to rush you again.
Okay.
Dr. Okezie, I'm really sorry because we still need to do the interactive session. So if you can be brief, we really would appreciate that. And I have already introduced you before, so I won't be reading a bio. Thank you so much. Please go ahead and please be mindful of that. Hello, Dr. Felix, are you there?
Hi, yes, I'm here. I'm sorry, I lost you a bit. Did you ask a question I needed to respond to?
No. I just said, given again, I apologize because you're like one of the last speakers, and it seems like we're rushing you again. But I'm just asking you to be mindful of the fact that we still have to take questions from the audience, and so we would appreciate you cooperating with our time. Thank you so much.
Thank you.
Okay, so I think we need to go, we should go into the interactive session, and then he will field questions when any are directed at him.
I didn't actually bump him off. I said he could present. Just be mindful about it.
Yes. Can you do you want to say a few words before we go into the interactive session? Dr. Felix?
Oh, all right. So I didn't quite realize you wanted me to make a contribution at this time. I think I have actually sat through the entire period just to gain maximally from what's being said, because one of the key things about access to care in Nigeria is this issue of reimbursement. How do people get coverage? How do people pay for healthcare? If you're in the private healthcare space like myself, you'll find that that's one enduring problem that we face all the time. We keep being inundated by people who need care, emergency care, urgent care, or elective care, and they're just not able to pay. So I think that one of the interesting takeaways from this would be if we can actually form our thoughts about how 200 million people could get coverage to pay for care. I think that will really be a good thing to take away from here. Health insurance is it's a very good way to go. I agree that the width before the depth in terms of being able to cover most people for just a few basic things, that will also help. I'm also happy that the Basic Healthcare Provision Fund is being mentioned again and again. I'm also a part of the implementation of that care fund from the emergency medical service part, and which is why we talk again and again about this fourth layer of healthcare, emergency medical service, because whether you've got health insurance or coverage or not, once you have need for emergency medical care, you should have it. Otherwise, at that point, there may be a loss of life or limb if you don't get the care that you deserve. Therefore, as part of the Basic Healthcare Provision Fund, with the guidelines, 2020 guidelines that have been passed, we're looking at starting of the National Emergency Medical Services and Ambulance Scheme, which should be able to leverage on that fund and be able to provide Nigerians emergency care anywhere they live. One of the hallmarks of this has been very pushed a lot by the Honorable Minister of Health is you don't expect people to pay for emergency care when they need emergency care. And emergency care needs to come to people. It just needs to come to people. And there are two ways that comes. First is the emergency ambulance service. So the NEMSAS, as I mentioned earlier, that's the acronym for the National Emergency Medical Services and Ambulance Scheme, will be working with a vast number of providers to be able to roll out ambulance services or to support state ambulance services all over the country, and then provide emergency transport to people and treatment along the point where they need care. The second part, of course, of the emergency medical services is the acute care centers. This will usually be secondary or tertiary care institutions that people will be taken to for acute care. It's important that we start to get emergency medical service right in Nigeria. It's not a very good thing to talk about or think about that in most other countries you have the 911 system, 999 system, 111 system, all over the place. But in Nigeria, you really don't see a defined emergency medical service. So our system should begin to take shape soon. It's going to be based on the code 112. And we hope, and we really, really hope that at the very long last, we'll be joining the team of nations that have defined emergency medical services. Thank you.
So much. That is so awesome. Thank you. All right, so we'll move straight to the interactive session. Dr. Chioma Nwakanma will be taking over from here. Our able co-facilitator. Go ahead.
Thank you so much, Dr. Nkem. Thank you so much to our panelists, and a very big thank you to the participants who have been with us since the onset of this roundtable sessions. So, yeah, it's time for us to go right straight to the questions that we have for our panelists. Before I go to the Executive Secretary of the NHIS, I would first ask this question that was directed to Mr. Abajue, the CEO of Hygeia. I don't know if you're here, sir. I have to say I really enjoyed your session, and one thing that I agreed with strongly is the fact that you said that data is not in the open, and the NHIS should publish data and financial reports. So this question is asking, considering we have a very large informal sector with a potential source of significant revenue, what suggestions do you have on how to include this informal sector? Also, is the initiative to capture the informal sector in Lagos State, which is spearheaded by Farm Access and Hygeia, using a digital platform replicable on a national scale? I don't know whether I spoke too much English, but I'm just going to break it down. This person is trying to find out how we can be able to include the large informal sector, seeing that most Nigerians fall under this category. And then if what is being done by Farm Access and Hygeia, that's the digital platform, is that replicable on a national scale? Thank you.
Okay, thank you very much. I actually did answer the question online because I thought it would be important to keep it for the records. But there are two questions inside there, and the first one is about the informal sector. And yeah, I chose earlier in my comment, and I spoke about focusing on results. So when you think about capturing the informal sector in practice, one suggestion I have, or actually a two-part suggestion is, one is, it begins with, first of all, declaring health insurance to be compulsory. Because where there's no law, nobody can be in default or outside of it. So you just help compulsion, you help participation by first telling people that they must do it. So that's the one part. But it's one thing for you to tell people that they must do something. It's another thing for them to actually do it. So what is the best way of helping people do it in practice? We have tried many different routes, many different approaches, and it's important to always invest in communication and advertising. But I think that we've learned that what has worked in Nigeria is toll gates. So where is the toll gate that actually helps people to come in? All right. And that toll gate needs to be at the hospital. So if we make it mandatory for hospitals to collect insurance, not cash, all right, then everyone that goes to a hospital wants insurance. If, however, you want to pay cash because you don't have insurance, and every country in the world has this system, all right, if you want to pay cash, then there's a special tax. It's a VAT on it, all right? So the people that say they are carrying around their cash because they'll pay when I have, because I have the money, no problem, pay and contribute to the purse. All right. So at that point, all right, we will take a special tax from you. All right, that is VAT. If you want to avoid that, then go into the pool and go and join the pool and come with your insurance, and we can track it. And the moment we start publishing results, it will be auditable. All right, and we can track this thing and we can get people to participate. Otherwise, we'll have plenty of theories, but in practice, they will not deliver the answer. The second question asked is about the Lagos State model and whether it is scalable on a national basis. The answer, to be straightforward, is no, it's not, all right, because there are many things in there that are unique to Lagos State. However, all right, the principles are. So if you amend the principles of the Lagos State structure, especially dealing things with about ambiguity and the way you're implementing it, it has to be pragmatic for the environment. If you take the Lagos State model to Edo State, it will fail. All right, unless you adjust certain parts to make those adjustments for it to then be applicable in different environments. Remember that each state is legislating based on the nature of its own population. So you cannot take the demography of Lagos State, impute it to someone else, and then treat it the same way. So the answer would be no, you cannot scale it that way. All right. But if you take the principles behind it and then make adjustments to it, then to be applicable and on that basis, perhaps scalable. Thank you.
Thank you very much for that that robust reply. Thank you so much. I'm going to be channeling the next question to the Executive Secretary of the NHIS, Professor Mohammed Sambo. Are you still with us, sir? So this question came with a feedback, but I think because of time, I'm just going to go straight to the question because I think our conversation has already given it some kind of context. So it's saying with a significant percentage of Nigerians working in the informal sector and a greater proportion living below the poverty line, what is the plan to expand universal health coverage with that sector? That's the informal sector. What is the plan to expand universal health coverage? This question is from Beva Ibinosun from the University of Pennsylvania Law School. So over to you, sir.
Okay, thank you very much. Am I online?
Yeah, we can hear you clearly.
Okay. The National Health Insurance Scheme has developed a concept of health insurance under one roof, where NHIS and state health insurance agencies are working together in a coordinated fashion. Based on that health insurance under one roof, we have collectively agreed on what is called matrix of coverage, where we stratify all the segments of the population and who covers them and how they will be covered. This is very crucial if you want to systematically implement the national health insurance for attainment of universal health coverage. There are two things that are very critical. There are people that are salary earners whom you can quickly get their premium deducted. There are people that are in private sector who are also salary earners, and you can easily deduct their salaries. There are large population of informal sector who are either self-employed or working in a very small organization. Then there are other segments of the population who are regarded as vulnerable, and no matter what, they will not have the ability to pay based on their socioeconomic standing. So we have developed this comprehensive matrix. In addition, there are other groups that are retirees, either of public sector or private sector. There are children, maybe university students, who are above 18 years, and so on and so forth. So we have developed this extensive matrix of coverage in collaboration with the states. And we have identified which group will be covered seamlessly by the National Health Insurance Scheme and which group can be covered seamlessly by the state health insurance agencies. And we have identified the vulnerable groups who cannot, by virtue of their socioeconomic status, be able to defray the premium that is required. So we are going to go systematically to ensure that all those that can be covered based on their ability to pay are joined either the formal sector social insurance at national level or at state level. And those who have ability to pay and they cannot be able to, and they are not under any organized setting, we will organize them through the gift shift program so that they can come into the ecosystem, either at the level of NHIS or at the level of state health insurance agencies. Then we have a matrix of the vulnerable who cannot be able to pay. the basic health care provision fund is designed to cover the most vulnerable segment of the population. So we are working with the state to ensure that those vulnerable groups are those that will be covered by the basic health care provision fund. But we are very much aware that the money that is generated from the basic health care provision fund will not be able to cover this vulnerable because of the high number we have in the country. That is where we are muting the idea of innovative financing so that we can have opportunity to draw more resources from philanthropists, from other organized sector, from other innovative financing mechanisms, so as to be able to cover the vulnerable segment of the population, probably the people with disabilities, probably people that are aged and they are not under any pension, probably women within reproductive age group that fall into the category of poor. So that matrix of cover is very comprehensive, and we have developed a blueprint on this health insurance under one roof, which clearly outline all these modalities of coverage. And if we go systematically in this manner, by the year 2020, in the next 10 years to come, we should be able to say that we have almost achieved the universal health coverage. So the informal sector will have opportunity to come into the gift ship program. And the whole idea why we need to bring informal sector into that, so as to benefit from large pool that is very necessary for the existence of any social health insurer. All those small social health insurance arrangements are not sustainable, because health insurance, the success of health insurance will depend on the level of cross-subsidization. And ability to achieve cross-subsidization is a factor upon the large pooling you have, so that people can come, people that are sick can come and get treatment without jeopardizing the pool of the national health, of the health insurance system. I want to stop here.
Okay. Thank you so much. I just want to ask a follow-up question to that. I can see you have, there's a whole lot that you're working on, and we can feel the passion that you have for what you do, and we're really grateful for that. So I want to ask a direct question, sir. Where can we find this data? You keep mentioning we're doing this. How can we be able to see what you're doing? Where can we be able, as citizens, how can the public access what is being done on your end, firstly? Secondly, the people you want to reach out to, or we're looking to reach out to, do you have data of the number of citizens that we have in this country? Do you have data of the vulnerable people? Do you have data how can you be able to help those you want to help if you don't know who they are and where they are? I think that's the primary issue. So do you have that data? Just in a few seconds, if you just answer that, then we move to the next. Thank you.
National Health Insurance Scheme I met is not working with any data. So when I came last year, I didn't inherit any data. And there is not even any strategy to attain universal health coverage. For the first time, NHIS has developed a 10-year strategic plan. The plan is before the Honorable Minister for approval. The strategic plan has one complete chapter on how to inform, educate, and communicate to Nigerians on various health insurance program and arrangement we have. Because if you look at the 3-point rebranding agenda, these two things you mentioned is perfectly fit into the second agenda of engendering transparency and accountability. If we disseminate our strategic plan, you will see a comprehensive section that is talking about information strategy, strategic information, and communication, and strategy for communication. So we are going to roll out that information technique. And all this issue of reaching out to the population in terms of media and method for reaching out to Nigerians are well captured in our strategic plan. So the issue now is to communicate to Nigerians and how to roll it out. And secondly, one of the things that I've started fighting in when I come to the National Health Insurance Scheme is that all the percentages that is being branded by the media is unfounded, because National Health Insurance Scheme doesn't know the denominators of all the people that are supposed to be covered. So as I said, we are going into systematic process. If we now that we have developed a plan and we have developed a matrix of cover, we are going to work with international agencies to support us to take a census of all these denominators, because we cannot be able to say that we want to cover people with disability in the country when we don't know how many of them, when we don't have their spatial distribution. These are a lot of work that needs to be done. That's why we are mobilizing international agencies to come and work with the National Health Insurance Scheme. There is a fertile ground to develop National Health Insurance Scheme now. And international agencies that are interested in various aspects will come. We will set out a process of generating all these denominators. This will help us to determine how many are there and how much is required to cover them. By the time we finish all this groundwork, we will be able to tell Nigerians that for us to achieve universal health coverage, we need X trillion or we need X billion. And when we have this X billion, we know who are to be covered by this, by this amount, and we know where they are located.
Okay. Thank you so much, sir. I'll just hand over to Barrister Obinnia to make a quick introduction, and then we'll come right back. Thank you so much for that.
Thank you, the Executive Secretary of NHIS. That has been very enlightening, especially the fact that you met no data when you joined or when you assumed the position, and that you're currently making plans towards that. It would be nice, actually. We actually at A-Sense are looking forward to that document that you mentioned. Thank you very much. Permit me to quickly, we have with us a senior rep of the World Bank. He joined in, and he has a few words for us regarding the issue at hand. So I'll just let him speak. Dr. Olumide Okunola, are you with us, please?
Yes, thank you. I don't know if you can hear me loud and clear.
We can, okay. And we'd also like to see you, sir.
Well, I'm not sure if that's possible. However, let me just quickly make my comments. Thank you very much for a great conversation and discussion. Particular kudos to Professor Sambo. Certainly the World Bank is one of those institutions they mentioned that will be keen with helping him achieve those transformational reforms at the NHIS. However, just a quick, some quick comments. My first comment is, in discussing health financing reforms, the conceptual framework you use is, look, where is the money coming from? Revenue raising. How do you pull the money? And how do you purchase? So technically, health insurance is not necessarily a method of raising revenue that can be pari passu compared to tax-based financing. Health insurance is a way to pull, to purchase, because you can still have tax-based financing and still use health insurance. You can still have revenue contributions and still have health insurance. So it's just important to make that distinction that how you raise revenue is a different framework on its own. And I do hope people on the call have that nuanced understanding of that. The second point I'd like to make, which has been emphasized on the call, is the concept of universality. When you are discussing financing health insurance and all of that within the context of universality, then all citizens matter. So, for instance, Obinnia made an excellent point about, look, what if by magic we're able to cover everybody in the formal sector? Yes, that was the thinking for health insurance 20 years ago. Let's start with the formal sector and then we move to the informal sector. But then When you do that successfully, for instance, you will have such a high level of inequity. So the kind of reforms you're doing on the formal sector must be accompanied by reforms on the informal sector to make sure that especially those who are impoverished because of accessing care must be part of that pool. That is why the idea of universal health coverage help us move this discussion forward. You cannot say, oh, formal sector, those in the private sector. No, you must think of everybody holistically. And then that brings me to the third point in terms of what is the point or the role of mandatory health insurance. And let's be clear about this, especially for participants on the call. Mandatory health insurance does two things. It does two things. The first thing it does is that it allows what the model Obinnia has mentioned to be actualized. That is, the people in the formal sector don't go anywhere to run to. They must participate. That's the first thing it does. The second thing it does is, because you have made it mandatory, governments must now pay for those who cannot afford it. So in actual fact, when we talk mandatory health insurance, and I do hope our parliamentarians also are picking this, it puts pressure on governments to say, then you must be ready to budget for them. So in other parts of the world that have achieved universal health coverage, in fact, they just pay for everybody in the informal sector. They don't even bother to identify. But then some people will say, look, since we can't cover everybody in the informal sector, let me try and distinguish, and that's where the question of the missing middle comes into play. This is a question that remains unanswered. But for instance, the matrix that has been described by Professor Sambo actually would help. And my last point has to do with, it's neither tax-based or health insurance. When you raise revenue, you need to then be able to say, how do I purchase effectively? And that is the role of the health insurance as an organization. Please permit me to emphasize that right now, Nigeria is using two approaches in terms of pooling and purchasing. You are using the Federal Ministry of Health, you're using state ministries of health to pool and purchase. At the same time, you're using health insurance to pool and purchase. Nigeria must make a decision. It cannot follow those two dual tracks. If today you merge the monies that is going to through the ministries of health, state ministries of health, and pull that to the health insurance agencies, there will be more money to cover more people, and it will be a much more effective way of delivering healthcare services. Thank you very much. I appreciate it.
Thank you so much. That was really spot on and powerful. Thank you so much, sir. I'm going to start. We have like one more question for the Executive Secretary of the NHIS. And before that, I'll just read out a quick comment from one of our participants, Sani Abdullahi. He said, poverty and illiteracy, they are part of the major issues that we are encountering in Nigeria. Once these are solved, then we can resolve our issues. And I think I quite agree, because some of the things that were just said right now by the last speaker begs the question, how many people know what we are discussing here today? So that shows us that a lot more people, a lot of Nigerians are unaware, they are not uneducated about this issue of insurance. So if you can't tell them how important insurance is, how to access insurance, make it really something they want, then we're still going to have a problem, because no matter how beautiful we make it, it's still going to be unappealing to them. So the next question says, okay, it came with a whole lot of, okay, it said, is there a plan to strengthen the implementation of the scheme that's pertaining to vulnerable groups? But I already think you mentioned it, so I'll go to the next one. He said, are there thoughts around increasing financing sources to expand healthcare coverage within the country? So are there thoughts around increasing our financing sources to expand healthcare coverage within the country?
I think the contributor has not listened to our discussion.
Right.
If she has listened to our discussion, we aggregate all the possibilities where the monies can come, and we also brought out the limitation, and we also discussed the plan to have innovative healthcare fights.
Yeah. Okay. Thank you very much, sir. I think that's about that, because most of the questions that we've been getting, I think most of them have been answered by our panelists, and some of them are just repetitions of other questions. So what I did was to put them together and just ask as one. So thank you so much to our participants. Thank you so much to our panelists, and thank you so much to everyone who has made the session so far very interactive and interesting. I'll just hand over to Obinnia now, Barrister Obinnia, to take over from here. Thank you.
Thank you, everyone. Thank you for that brilliant contribution, Dr. Olumide from the World Bank. We are about to round up. This has been very enlightening, has been very informative. There's a lot of work to do ahead, which we'll get to after this, but I'd also like to hand over to the spokesperson of the House, Honorable Benjamin Kalu, who is the chairman of the Media and Public Affairs Committee. This program is actually possible because his committee saw the need to open a channel of engagement between the Parliament and the Nigerian public, sector by sector. So I'll just hand over to him to say a few quick words as we round up this engagement. Then before I deliver a closing remark. Over to you, sir.
Thank you, Obinnia. Thank you, the moderators. You've done a lot today. You know, when we say nation building, it's a joint task. You don't need to be a legislature to be able to do what you have done today. You don't need to be making laws to achieve what you achieved today. What you have done today is to increase our knowledge base, to help us in forming our motions and our bills, which remains the instruments with which we work. We're not going to have empty motions again when it comes to the health sector. We're not going to have bills that does not relate to what the realities are. With the feedback mechanism, which I know ACE is working on, I know that the documentation that will come out of this engagement is going to be very resourceful to the leadership of the National Assembly, not only the House of Representatives. As you are aware, we practice a bicameral system of the Parliament. What comes from us goes up to the Senate, and vice versa. So today you've heard from a senator, and though we were inspired to do this, they have made their contribution, and I'm sure that the ears of the National Assembly has been fueled by people who have the right voices to address the right issues. You've not wasted your time. I must assure you, it's a very important period for us during this budget appropriation, that we're running around. But for me to be here from beginning to the end means a lot because we want to harvest what will help us serve Nigerians better. The speaker has been getting feedback of what has been happening here. We've been recording and sending to him. And all the leadership of the House, they are impressed with what we are doing. This is the first time that such a thing, when we talked about it, we felt, is Nigerians, would they embrace it? Would they love the idea to engage Are they desirous to help us in bridging this information gap? And today it became a reality. And I'm sure from health, Nigerians will suggest to us the next sector to go into. And I pray we find quality men and women like you in other sectors who understand the sector and who are able to contribute to what will make us come out with good policies, come out with good laws that will better our nation. Emphasis on our nation, because we don't have any other nation than this. And what we make out of it is what we will leave for the generations unborn. I appreciate you so much. And you've written your name in gold, your names in gold. When the Green Book will be out, we are going to highlight the roles you play through this conversation. It is not going to end today. We just started the conversation. And you should not be surprised if we write to you again for the second phase of this engagement. You know, the topics around health sector is wider than what we handle today. And I'm sure having taken the right first step, other steps will follow. So when we knock on your door asking you to come and contribute again, please be willing to make this sacrifice. It's a sacrifice that is worth it. At the end of the day, you'll be proud of what we have been able to achieve in the health sector through partnership, this strategic partnership with you. Once again, thank you. And the ACE team, and God bless you.
Thank you. Thank you, Honorable Benjamin Kalu, the official spokesperson of the House for that. So on behalf of ACE Center, I would like to thank everyone for participating in this meeting edition of the 9th Sectoral Roundtable Sessions on Health. Like the spokesperson of the House mentioned earlier, the essence of these sessions is to create an ongoing channel of engagement and feedback between the House and various socioeconomic sectors of the nation. At ACE Center, we are committed to creating change one sector at a time, and we look forward to engaging with other sectors of the nation. We believe that constant civic engagement will increase transparency, accountability, and strengthen our democratic institutions. And our conviction is that we should have evidence-based policy making, which should be done in consultation with the people who stand to be affected the most by the legislation or policies in their sector. So I especially want to thank the House of Representatives and especially the Media and Public Affairs Committee of the House and its chairman, Honorable Benjamin Kalu, who just spoke, who have given us this opportunity to actualize and facilitate this initiative. We are convinced that the leadership of the 9th House of Representatives is committed to impacting the lives and well-being of all Nigerians. We also appreciate the participation of members of the executive, the Minister of State for Health, Honorable Adeleke Mamura, who was on earlier today, the DG of NCDC, who gave a very powerful presentation yesterday, the ES of NHIS, who just made a very passionate presentation a few minutes ago. We also appreciate the legislature, especially Honorable Yusuf Sununu. He's chairman of the Health Services Committee. He joined us yesterday. Honorable Pascal Obi and his deputy, Honorable Martin Soke, they are the chairman of the House Committee on Health Institutions. They supported this initiative. We appreciate the international development agencies who sent participants. Dr. Walter Mulombo of WHO was with us yesterday. Professor Kevin Chika-Rama of African Development Institute also gave some contributions. Dr. Hadiza Kamofu of FHI 360 was with us yesterday. We also had Dr. John Adedoyin of MSH. We had Dr. Sanjana Bardwaj of UNICEF. And we further appreciate participating stakeholders like Dr. Ibrahim Wada of NISA Premier, who made a very passionate case for PPPs. In fact, PPPs seem to be a very focal point of all the deliberations today, the importance of public-private partnerships in the health sector. We appreciate Senator Tejuosho, who just spoke to us of LISDEL. We appreciate Dr. Gafar Alawode of LISDEL also. Professor Innocent Ujia is the NMA president. Dr. Felix Ogedebe of Cedar Crest, Dr. Ola Orekumri of Flying Doctors, who had a very bold and challenging idea on monetizing our brain drain. We also appreciate Mr. Obinnia Abajue of Hygeia HMO, Dr. Francis Ilika of Palladium, Mr. Lanre Olapoju of KPMG. I thank all the panelists and moderators for taking the time and effort to share their knowledge and contribute to this conversation. I also want to thank the entire AIDS Center team, especially Jacqueline, Vanessa, and Linda for their industry and dedication. Of course, I must appreciate our very, very able moderators, Dr. Nkem and Dr. Chioma Nwakanma. You have really helped drive this conversation to very productive actionable points, outcomes. And finally, to all the participants, I must say a big thank you. We are amazed by your enthusiasm, and we appreciate all Nigerians who desire a change in the way policy making happens in this country. Your feedback has been received, and we'll collate and document all of them in the Green Book, like the spokesperson of the House mentioned, which of course will be presented to the Speaker of the House and will help guide the activities of the House. We also hope that you can use that to track our progress. We remain committed to ensuring impactful deliberations. Therefore, I can assure you that the bills and motions are going to emanate from the bold ideas and recommendations that have been made in all these sessions. And I encourage everyone to look out for more announcements regarding this engagement. So thank you once again, and we hope to see you all at future sessions of the 9th House of Representatives Sectoral Roundtable session. Thank you very much and have a good evening.